Hi everyone, and welcome to our Tech and Learn today. My name is Kelly Walker, and I am a licensed mental health counselor. I'm going to be one of 3 presenters today. Like I said, I'm a licensed mental health counselor. I work in private practice in Winter Park at Climb Counseling with Morgan Rahimi, who some of you already know. I am trained in advanced perinatal mental health, so this ranges from peri or postnatal depression and anxiety, pregnancy loss, infertility issues, and honestly, just a lot of parents who are transitioning into parenthood and trying to figure out how it all works. I am also a certified clinical trauma professional. I'm trained in sand tray therapy, expressive arts, and mindfulness practices. All right, so let's begin. The way that pregnancy is portrayed on magazine covers and in the media is vastly different than how a lot of women feel during pregnancy. Not sure how many of you have gone through a pregnancy, but it isn't always rainbows and sunshine. There are a lot of ups and downs. There can be morning sickness or all-day sickness, and there are a lot more doctor's appointments than fancy photo shoots. There are healthy pregnancies and high-risk pregnancies, and sadly, a pregnancy is not a guarantee that there will be a baby at the end of it. There are a lot of assumptions about pregnancy and how babies come into the world. Some assumptions might be that all pregnancies are wanted, or that they come about naturally. For some couples, it can take years to achieve a healthy or viable pregnancy, and as professionals, we just really need to be aware of this. So I'm sure there's a lot of words that come to mind when thinking about pregnancy and birth. There's a lot of positive associations like celebrations and family, blessings, gender reveals, social media announcements, nursery, names, baby clothes. But for some people, there might be things like loss, infertility, shots, medication, depression, anxiety, trauma, weight gain, baby blues, etc. If pregnancy and motherhood were portrayed in a more realistic way, we might see things like this. We might see stretch marks. We might see middle of the night feedings, moms and dads pacing their house for hours on end, trying to get that baby to sleep. We might see frustration about not knowing what cry that baby is using, or the feeling of being alone or longing for that kid-free life. I believe that the more we talk about postpartum depression and anxiety, the more that we normalize it. Let's see, these celebrities came out and shared their struggle with the world. Some were criticized, even ridiculed about it, and some people were praised for their bravery to speak out. In 2016, Adele came out and said, "I had really bad postpartum depression after I had my son, and it frightened me. My knowledge of postpartum, or postnatal as we call it in England, is that you don't want to be with your child. You're worried you might hurt your child, or you're worried you weren't doing a good job. But I was obsessed with my child. I felt very inadequate. I felt like I'd made the worst decision of my life." There's not a singular way that postpartum depression manifests itself. It can show up in lots of different ways. Brooke Shields said, "I really didn't want to live anymore after her child was born. Simply seeing a window was enough to prompt me to think, I just want to leap out. But then the rational side of me would say, you're only on the 4th floor. You'll get broken to bits, and then things will be even worse." Like I said, the more we talk about it, I think the more we can help people understand how common this actually is. On an episode of Blackish, I think it was in 2017, they showed Rainbow Johnson's character in the midst of postpartum depression. Her character was always portrayed as this strong, successful doctor, a great mother to her other children, and then she experienced this depressed state. The writer of the show was quoted to say, "There's all this pressure from society to be this perfect thing. People say that being a parent is supposed to be the happiest time." And for her, she experienced postpartum depression, but she said that she wanted to show people that for a lot of women, it's the hardest time and they feel like they're doing it all wrong. She said that she hoped by showing this episode that viewers would say, I didn't know it was okay for me to feel this way and that I could ask for help. So when does perinatal depression begin? Up to 60% begins before birth. Some women struggle with mood disorders, depression, and anxiety before they ever get pregnant. And for some, it begins during the pregnancy, and then around 40% get it in the postpartum period, which is the first year of the child's life, or the first year after delivery. There's biological and social risk factors that include genetic predisposition to depression and anxiety, also stressful life events, inadequate social support, poor relationships with spouse, low self-esteem, childcare stress, and one that I commonly hear in session has to do with the temperament of the child. What is the difference between the baby blues and postpartum depression? So nearly 80% of women will experience the baby blues. It's a very natural thing that happens just due to the change in hormones after giving birth. And that will usually dissipate after the first 2 weeks of giving birth. Research varies, but it shows that 1 in 6 to 1 in 7 will experience postpartum anxiety or depression. This includes mood swings, excessive crying, difficulty bonding with baby, overwhelming fatigue, sleeping too much or sleeping too little, hopeless feelings that things will never get any better or that they'll ever sleep again, prolonged fear or worry that they're not a good mother, that baby would be better off without them, and there might even be thoughts of harming themselves or the baby, or even thoughts of death and dying. Many moms feel guilty and think that this is their fault, and Postpartum Support International, I love what they say. They say, you are not alone, you are not to blame, and with help, you will be well. Lastly, postpartum psychosis. This affects a very small percentage of people, but it is very significant and it can be very severe, so we should not pretend that it does not exist. Signs and symptoms might include confusion, disorientation, obsessive thoughts about baby. Sometimes this comes out as worrying about harm coming to the baby, like if there was a block of knives on the kitchen counter, maybe that, oh my gosh, what if that fell and hurt my baby? There's postpartum OCD. That's something that we weren't really going to get into today, but that falls under the perinatal mood and anxiety disorder. But with psychosis, it's a break from reality. So it can be hallucinations, delusions, like I said, obsessive thoughts about baby, and it can also come out as severe paranoia, and then excessive energy or agitation. So circling back to something that I mentioned in the beginning, not all pregnancies come with a baby at the end. So 1 in 4 pregnancies end in loss, and 1 in 8 women or couples struggle with infertility. So with those statistics, it would surprise me if not everybody tuning in today hasn't been affected by loss or infertility, whether it be yourself, a friend, or a family member. So during pregnancy, there are so many doctor's appointments. There are lots of medical screenings and tests done. But as you can see here, one of the things they test for, gestational diabetes, it affects 2 to 5% of pregnant women, hypertension, 6 to 8%, and the rate of postpartum mood and anxiety disorders is at 15 to 20%, but it is the lowest thing to get screened and treated. So this is something that has to change. Another consideration we need to talk about is perinatal mental health and breastfeeding. So breastfeeding is a personal choice, and if moms have planned to nurse their babies, there is actually a decreased risk for postpartum depression and postpartum anxiety. But if a mother planned to breastfeed and is unable to, whether there's lots of different reasons why people can't nurse, whether that be like a medical issue or baby can't latch or not producing enough milk. This actually increases their postpartum depression and anxiety risk. And then moms who did not plan to breastfeed and for some reason end up breastfeeding their baby, this population would have an increased risk as well. So as professionals, we need to be advocates for women. We need to encourage them to do what is best for them. There's a lot of shame and a lot of guilt around the breast is best idea, and that just might not be best for some moms, and that is okay. Okay, more about breastfeeding and medication. So if a mother has postpartum anxiety or depression, or maybe they were dealing with depression before they got pregnant, maybe they were on some type of antidepressant or anti-anxiety medication, there's more and more research coming out about the safety of medications during pregnancy and during breastfeeding. And we need to advise women that they should not just stop medication because they find out that they're pregnant. This can actually do a lot more harm than good. I think moms really need to get in with their physicians and have honest conversations and weigh the risk and the benefit of having depression or anxiety go untreated versus exposing the baby to a very, very, very minimal amount of medication through pregnancy or through breastfeeding. Postpartum Support International actually has a perinatal psychiatric consultation line that is completely free to prescribers, where they can consult about best medication practices for pregnancy or breastfeeding. And I think not a lot of providers know about that. So we can get that information to you guys as well. I hope I covered enough, but not too much for you guys to understand. And if there are any questions, I'm sure any of us would be happy to answer. You can email us or reach out to us on the phone. We'll make sure to get that information to you. And now I will pass it along to Kimberly.
Hello, everyone. My name is Kimberly Fan. Thank you, Kelly. I am a licensed mental health counselor in the Central Florida area. If you are from Central Florida, I am in Oviedo. I have a practice there. I am trained in the basic and the advanced trainings for perinatal mental health, and I'm sitting for my certification exam this summer, so that's very exciting. I primarily work with teens and women. Mostly who are going through just change and adjustment in life. I work with a lot of anxiety, a lot of trauma, a lot of grief and loss, and obviously specialize in perinatal mental health as well. So, here we go. So I'm going to kind of continue on with our presentation. So first of all, these numbers are from, this top numbers from 2018. In Florida, there were 221,500 live births, and 40,000 of those were born to parents experiencing perinatal mental illness. So that's about 20%, which is big. That's a big deal. So I think most of our attendees who are attending this training are in the Central Florida area. However, there might be other people here as well. So just for you guys to know, if you're not from Central Florida, Orange County is the fifth most populous county in Florida, and that's kind of the main county in the Central Florida area. So in 2017, there were 16,887 live births in Orange County. And as you can see here, between 2,500 and 3,400 women and men had a PMAD. So PMAD is perinatal mood and anxiety disorder. And then 17 to 34 of those cases had postpartum psychosis, which we'll talk about in just a little bit. So this, this slide is just to show that perinatal mood and anxiety disorders are a big deal, and this is happening often. So, yeah. Okay. So more than 58% of moms in Florida experienced postpartum depression symptoms months after childbirth in 2010. And in 2010, the numbers were that about 10% of mothers who reported experiencing the symptoms sought professional help. More recent numbers from the Blue Dot Project in particular show that about 15% reach or receive treatment, but that is still a really low number. So we, are definitely actively trying to increase that number and have moms and families get more support than what they're getting currently. So, yeah, and we'll talk about this again in a few minutes, but just kind of with these numbers, the number one complication of childbirth are perinatal mood and anxiety disorders. So that's a big deal. And there's more new cases of mothers suffering from maternal depression each year than there are women diagnosed with breast cancer. So big deal. All right. So here we are just kind of talking about the higher risk groups. So I'm not going to read through all of these, but you can see some of some of them here are non-Hispanic Blacks, if people are younger than 19 years old, or if mothers are 35 and older, people who only have a high school education, and then I'll let you kind of read through the rest of those. So those are groups that are higher risk of developing a perinatal mood and anxiety disorder. All right, so baby blues, this is something that you might have heard of before. So baby blues are common and these are okay. This is when we're not clinically concerned. So these are experienced by up to 80% of childbearing women. Some of the symptoms go right along with everything that's happening right after someone has a baby. So there's tons of hormonal changes going on, obviously the adjustment to having a new baby. So you can see here symptoms include irritability, tearfulness, anxiety, overwhelm, sadness, happiness, all of the things. So what we want to look for here is that these symptoms usually take place within the first week after postpartum, and they only last about 2 to 3 weeks. If they're lasting longer than that, then that's cause for concern. That's when we want to get them in to their OB for some type of screening or assessment, and potentially on to a therapist for treatment. So yeah, and then like it says here, this is not a mental health disorder. These are okay. So, all right. So the evolution of PMADs, a long time ago, there was a time when mothers' emotional challenges during a postpartum period, it was all labeled postpartum depression. That's just what it was. That was seen, that was how it was seen by media, by everyone really. Over time, there's been more recognition that there are emotional challenges beyond just postpartum depression. So it also expands to postpartum anxiety, or panic, or OCD, and other things. And so, hence the newer term now, PMADs, or perinatal mood and anxiety disorders. And so that really helps capture the range of disorders and not just, oh, she has postpartum depression. So, like I said a couple of minutes ago, the most common complication of pregnancy are perinatal mood and anxiety disorders. It's more common than gestational diabetes, preterm labor, and low birth weight. And this is experienced by between 15 to 20% of childbearing women. So, a lot of people, so we hear numbers, different numbers a lot. Sometimes we hear it's experienced by 1 in 7 women. Sometimes we hear 1 in 5 women. Clients say to me all the time, I think that there's this misconception of that they didn't develop it early on. So like, why are they developing it now? So I have women come to me all the time who are 6 months postpartum, or 8 months postpartum, or 4 months postpartum. And they say to me, yeah, but I had a baby so long ago, like I'm starting to adjust, the first few months I felt okay. So why is this popping up now? And it's actually really common for it to happen later on. So in the first 3 months, the newer research shows that there is 1 in every 7 women have some kind of postpartum mood or anxiety complication, 1 in 7 in the first 3 months. However, by the end of the first year, newer research is showing that it's really 1 in 5 by that point. So I think that's just, that goes to show that these can develop later. It's not just in the first 2 months or in the first month or whatever. So, yeah. Um, And then, yes, so the postpartum period is considered up to 1 year after postpartum, like you're seeing on this second to last bullet point here. And then I also just want to point out that 1 in 10 fathers experience postpartum depression. So I think, when we think of postpartum and we think of the perinatal period, a lot of people just think of moms, and that's really not the case. That can certainly be the dad or the partner as well. And so, yeah, it's 1 in 10 that are experiencing that, which is a big deal and definitely something that we look for when we are assessing not just moms, but families. All right. So risk factors. Um, Personal or family history of depression or anxiety. So, if the client has experienced depression, anxiety, bipolar, any of these things before, they are automatically at a higher risk for developing them in the perinatal period. And let me back up for just a minute. Perinatal means anything from trying to get pregnant to pregnancy itself to the postpartum period. So that's really encompassing everything and not just the postpartum period. You can see here lack of social support or marital strain, other life stressors like poverty, job loss, if there's been any grief, loss, death, anything like that. Also, pregnancies that happen either when someone is an adolescent or quite a bit younger, or if they're quite a bit older, or with unplanned pregnancies. And then, of course, if someone has a history of physical or sexual abuse, that can also complicate the postpartum period. All right. So this is a question I get a lot. How did I get this? How am I here? Where is this coming from? So as you can see here, there's 3 different categories that we break this into. Obviously biological, so the hereditary component, like we already talked about, hormones are a huge part of this. And if someone has experienced other symptoms during pregnancy, like depression or anxiety or panic or OCD, then of course they're going to be more likely to have it in the postpartum period as well. Um, and then, kind of going back to hormones just for a minute, we even look back to, obviously the hormones are changing so much right now, like during the postpartum period and pregnancy, of course. However, we even look back to hormones, like what was it like for them during puberty? If there was a lot going on for them then, and if they had a difficult time then that can also be a reason of why that pops up later in the postpartum period too. Um, Sleep is a huge part of this as well, if someone is getting enough sleep or not. And obviously, it's common that new moms and dads and families are not getting much sleep in the beginning. So that's a huge component. And then we even look at endocrine dysfunction as well. In the social category, you can see here finances, culture, things like that. And also, I think a big thing to note here, I've mentioned support network a few times, but I think also just the expectations and the responsibility that other people have on them. So, like if a mother is doing it all by herself, or if these are families that are military families or first responder families where one of the partners is gone for longer periods of time. Obviously, families that have teen parents or moms of multiples, these are also higher risk factors. And I think too, I just want to comment here for a moment. I think that there's going along with the support network part of this. There's a lot as far as still just advocating and awareness that needs to be done for this. So I think in the Western culture, we're so used to like, oh yeah, I got this, and it's all about productivity and and very much like a culture where you do things in smaller groups. And if we think back to decades ago or hundreds of years ago, or even Eastern culture where they're more community based, they have more support. So that can certainly be. Yes, working from home is so fun and something new that we're all dealing with right now, right? So yeah, that can certainly be a part of it too. And so I think sometimes women feel this pressure of like, oh, but I wanted this baby so bad, or we worked so hard for this baby, or I'm so blessed to have this baby, like I can't complain. But it can be that and, right? So it's that and of like, I am so blessed, and this is really, really hard. So I think just kind of normalizing some of that and validating some of that for the client is so important. And then lastly, you can see here psychological factors. So how a client thinks through things, how they deal with how they deal with stress and distress, some of their core beliefs, things like that can certainly play in. So all of these fall under PMADs. So we have the most, I think, well-known one, which are postpartum depression, postpartum anxiety, postpartum panic, but certainly perinatal OCD is a big one. And if someone has bipolar disorder before they get pregnant, then obviously that can be complicated during the perinatal period. And then you see PTSD here as well. We talk quite a bit about birth trauma when we're working with these clients, with certain clients. So yeah, some things to keep in mind there. All right, so talking about intrusive thoughts for a moment, I see a decent amount of these in my perinatal clients that I work with. So there is a big normalization piece around this. So it just in the way that these are common. They're not normal, but they're common, if that makes sense. So it's something that we're still paying attention to. But I do validate for my clients that this happens a decent amount. So you can see here that some of the intrusive thoughts can sometimes be focusing on the baby's safety, mom fearing that she might harm the baby. So this third bullet I want to talk about for a minute. Distress anxiety is clinically reassuring, which indicates thoughts are ego dystonic. So if we break that down for a minute, basically just that if these clients come in and they're saying like, oh my gosh, I had these horrible thoughts, and then I thought, but like, no, I would never do that. Would I? No, of course I wouldn't. I really wouldn't. Oh my gosh, I hate these thoughts. I want to get them out of my head so bad. They're so disturbing, right? So like you can tell that they are distressed about that and that they are upset about that. And so they are ego dystonic, meaning that they are not consistent with the mother's value system or beliefs or how she would normally think or do things. So that's a good thing. That's what we want, is that ego dystonic there. Yeah, so I was just making sure for my notes that I got everything. So, for example, I have clients that sometimes say like, well, what if I dropped the baby? And like, oh, what if I did that on purpose? Or would I ever touch my baby inappropriately? And then they're like, no, 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 of course I wouldn't. So these are the type of intrusive thoughts that we're talking about, and there can be a lot more too. So it's that like, oh, no, 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 I wouldn't do that, or I never want to do that, versus this last bullet point is talking about psychotic thoughts when the mother thinks that it makes sense. So if she were to be thinking, I have to take my own life because that's what's best for my baby, that's what's best for my family, and if she truly, truly believes that, then that is when we're kind of going into the psychotic thoughts, and we want to get her help immediately, because when those thoughts make sense to the mother, she believes that, and so then she is at greater risk and the infant is at greater risk as well. So moving on to postpartum psychosis. So this is really only seen in 1 to 2 moms per 1,000. So that number is pretty low. A well-known clinician who presents in the PSI and 2020 Mom basic training, I think she's been working with moms for, I think, 20 or 25 years, and she said that she's seen this twice ever. So it does happen. It's just rare, as you can see by this number here. There's some symptoms included there for you to review. Also, it's important to note, I think, that psychosis typically does not just come out of nowhere. So this is more common in people who have experienced or have been diagnosed with bipolar disorder before. So that is important to note. And then lastly, this is considered a psychiatric emergency. When this is happening, there can be really great risk for suicide or infanticide, and this is important for the mother to be assessed immediately, and typically an inpatient hold happens at this point. Okay. So we're looking at implications of PMADs on the mother and the infant. This chart is not to be looked at from left to right. It's just two separate categories here. So impacts that PMADs can have on moms, other chronic mental health symptoms, social withdrawal, avoiding the infant, or the opposite, where she holds on to the infant and won't let anyone else help or handle the infant. And then you can also see increased risk for abuse and neglect and maladaptive coping skills. Risks for infants that belong to mothers who have had PMADs are insecure attachment patterns, or just attachment issues in general, learning disabilities, and then cognitive and attention deficits as well. Okay. So in 2010, the American Academy of Pediatrics, the AAP, came out with these recommendations. These are not rules, they are just recommendations. So they said that there should be a screening at the 1, 2, 4, and 6-month well baby visit, and it should utilize either the EPDS, which is the Edinburgh Postnatal Depression Scale. That is 10 questions. It's kind of rated like you would check a box, either a lot, a little, not very often, or not at all, as far as like how are you feeling, how are you doing, what are you experiencing. So this is a good screening tool. This is not diagnostic, and it does not assess for severity, and it also doesn't ask about suicidal thoughts. So this is a common one, but it's this is an assessment tool, or I'm sorry, this is a screening tool, so you need to go on and have follow up and potentially treatment, depending on what these results show. And then another one that they said would be a good option is the PHQ-2, which is the Patient Health Questionnaire, and this is the short version. They have a PHQ-4, a PHQ-9, and so you can see the two questions that are listed on here. This is obviously self-report, and this is a really short screening just for possibly needing more intervention. So one thing that I just want to note on here is the reason that this was, or one of the reasons that this was given as a recommendation for the AAP is because if you think about it, a woman who has given birth they don't go typically for their first checkup to their OB until 6 weeks postpartum. And oftentimes 6 weeks is, pushing it if there's already emotional issues going on. Like maybe she's gotten through that baby blues phase, but maybe it's turned into something more at that point. And then if you think about how often the pediatrician sees the baby in the beginning, they're typically seeing them like a day after they get out of the hospital, or the birthing center, and then they're seeing them at the 2-week mark, sometimes at the 1 mark, definitely at the 2-month, at the 4-month, the 6-month, so they're seeing the moms a lot more often. So there's a lot more contact that the pediatricians have. However, my experience has been with this, and I think it's just important to note for advocacy purposes, is that yeah, I'll say personally and professionally, my experience has been that some pediatricians don't go into all of this. And I think that there's, reasons for it. Number one, the mom is not technically their patient, even though, of course, the mental health of the mom directly affects who their patient is, which is the baby. And then also, like, if someone screens high on this, then sometimes pediatricians don't have people where they can send them. Like, if they don't have referral sources for therapists in the community who specialize in perinatal mental health. So, so I know that some doctors, I'll speak personally for a moment. So the pediatrician that we take my son to, who I love, I think he's great and his practice is great. But whenever we go in there and, fill out the little form with, the developmental questions and whatever, it does have a couple questions on there, but I think it's is there domestic violence in your home? Are you struggling financially? And, do you need help for your baby? And then I think it asks if there's drug use in the home. So it's kind of like those three more general questions. So again, there's some gaps in treatment, and it's not anyone's fault. It's just where everybody can kind of like pour in a little bit more, and we've got to kind of figure out some better systems. So this is something that Postpartum Support International, PSI, talks about a lot as far as just the advocacy in catching these things so that we don't stay at that low 15% of women who are experiencing this get treatment. Um, so yeah, let me just make sure I've got all my notes on that. Yeah, okay, that's good. I think I got off my little soapbox now. All right, so now I'm going to turn it over to Nancy, and I hope you guys enjoy the rest of this presentation.
Hi everybody, my name is Nancy Layish. I am a licensed clinical social worker and one of the co-founders of Central Florida Postpartum Alliance. I am perinatal mental health certified and am actively involved in outreach and community education. And finally, I am a former Central Florida Postpartum Support International volunteer coordinator, and I am so happy to be here to present. If you have any questions or need further information about this portion of the presentation, please don't hesitate to reach out to me at nrlayish@aol.com. I will be speaking primarily about care management recommendations, or what I refer to as the care triad for perinatal mood and anxiety disorders, or PMADS. This includes education, ongoing preliminary screenings, and treatment referral. I will also speak a little bit about training opportunities as well as community resources and legislation that was recently passed here in Florida regarding perinatal mental health. We know that perinatal mood and anxiety disorders have a profound effect on mothers and a ripple effect on families and communities. Mothers often feel alone, experience feelings of shame, bewilderment, and often suffer in silence. PMADs are stigmatizing. Providers are often the first responders to clients suffering from these PMADs. Education starts with a conversation and is the first component of the triad. It starts with a conversation between the mother and her provider. This powerful dyad encourages the road to recovery as she is able to open up about her feelings while experiencing a powerful sense of relief that she is not alone and not to blame for what is happening to her. Ideally, this conversation begins as early as possible, which encourages ongoing assessment, screening as necessary, and treatment options. The sooner this process occurs, the sooner will be the mother's road to recovery. Providers are thus an integral part of the partnership and are critical to the client's wellness journey. So the American College of Obstetricians and Gynecologists issued this committee opinion regarding optimizing postpartum care in May of 2018. They said postpartum care should be an ongoing process. All women have contact with their OBGYN or other obstetric care providers within the first 3 postpartum weeks. A comprehensive postpartum visit should be no later than 12 weeks after birth, and it should include a full assessment of physical, social, and psychological well-being factors. In other words, a comprehensive psychosocial evaluation. Additional education resources include the use of social and traditional media, which provides widespread information about PMADs to large audiences, brochures and handouts, which offer user-friendly information about PMADs and are widely distributed by providers, agencies, hospitals, and support groups in the community. Education lays the foundation for screening and intervention for perinatal mood and anxiety disorders. Why screen? We know that there is a high prevalence rate of depression. We know screening increases the rate of detection. We know the risks of untreated PMADs are well documented, and we know that screening reduces the risks of depression. So I'm going to touch upon about several different professional group recommendations. They vary a little bit, but all of them agree that screening is crucial for assessment of PMADs. So on January 26, 2016, the United States Preventative Services Task Force recommended screening for depression in the general adult population, including pregnant and postpartum women, noting screening should be implemented with adequate systems in place to ensure accurate diagnosis, effective treatment, and appropriate follow-up. In May of 2015, ACOG recommended that all pregnant women be screened at least once during the perinatal period for depression, and since 2002, the American College of Nurse Midwives has advised midwives to integrate prevention, universal screening, treatment, and/or referral for depression into the care they provide. Now I'm going to speak a little bit about two commonly used screening instruments. These include the Edinburgh Postnatal Depression Scale, or the EPDS, and the Patient Health Questionnaire, or the PHQ. Both are publicly available and easily administered. Both have very strong reliability and validity. The Edinburgh is translated into several languages and is considered the gold standard among screening assessments. Both measure general depressive symptoms only, so this is the primary disadvantage. They do not assess for anxiety symptoms. A follow-up is needed for comprehensive assessment and diagnosis following the screening. I just wanted to make note of the EPDS regarding one of the components. They include severity ranges for the severity of PMADs. So they can range from none or minimal depression all the way to severe depression. And this is assessed through each question that has several responses. And each response is assessed a numerical value. Those values are tallied, and then the resulting score falls into one of these categories. Screening instruments are not diagnostic and therefore are never a substitute for clinical judgment. A positive screening only indicates an increased risk for diagnosis. Patients with positive screenings or who report other emotional distress must be referred to mental health providers for comprehensive assessment and follow-up. So I'm going to touch on treatment a little bit. We know that an availability and quality of perinatal mental health specialists varies widely among communities. For example, metropolitan areas likely have more resources and providers than rural areas. Maternity and pediatric care providers are encouraged to identify and develop professional relationships with at least one. For medication purposes, especially a board-certified psychiatrist specializing in reproductive psychiatry, if possible, licensed psychotherapist or psychologist, clinical social worker, family therapist, licensed mental health counselor, etc., who are experienced in treating emotional distress in childbearing women. Support groups provide another crucial layer of support and are integral to treatment for many clients. Mothers are allowed to unconditionally share their experiences with others who are coping with similar circumstances. The mothers know that they are not alone, which is very powerful and healing within itself. I'm going to talk a little bit about training opportunities. Postpartum Support International provides two. One is more like an introduction training called a certificate training, which is a 2-day and online training. And the other one is certification, which is a formal credential, which includes several different steps. The first one, you need to complete a perinatal mood and anxiety certificate course, such as the certificate training. Step 2 is to complete one advanced certificate training within a specialty area, such as mental health or psychopharmacology. And step 3 and 4 is to register and pass the exam. For OBGYNs, family practitioners, internists, midwives, and other types of providers, frontline provider training is offered as a webinar series, which is designed to teach providers to screen, assess, treat, or refer for perinatal mental health disorders. Mother Women is another organization that provides support group model facilitator training. I had the opportunity a few years ago to visit their location in Massachusetts and to see how they developed their group model training, and it's a pretty impressive resource. Their model has been replicated throughout the state of Massachusetts and within various communities in the United States. Um, this is fairly new. It's an evidence-based treatment of perinatal depression using cognitive behavioral therapy, which is a 2-day intensive training for graduate level or postgraduate mental health professionals. The Postpartum Stress Center, which is located in Pennsylvania, is a 2-day in-person postgraduate professional training program. And I'm sorry, the last one is I think a little bit cut off by my face here, but it's called the Selene Institute, which is located in New York, and it provides maternal mental health training both online and in person. Although I will mention that with COVID, nobody really knows in the near future what these in-person trainings are going to look like. So I recommend that you contact any of these resources for further information on that and for other information and questions. So with regards to local and regional information here in Florida, we have quite a few. There's ours, Central Florida Postpartum Alliance, Mothers Matter, Florida Maternal Mental Health Collaborative, PSI of Florida, which is Postpartum Support International of Florida, Postpartum Society of Florida, the Seventh Mom Project, the Alachua County Perinatal Mental Health Coalition, and Better Beginnings, which is a mother-baby partial hospitalization day program, which opened January 2nd of 2019. At Central Florida Postpartum Alliance, our mission statement is that we strive to raise awareness, provide support, resources, and treatment referrals to those impacted by perinatal mood and anxiety disorders. There are several ways to get involved with our alliance. They include quarterly meetings, diaper drives, documentary screenings, provider workshops, lunch and learns, and the Climb, which is known as the Climb Out of Darkness, which is an annual fundraising walk, very informal and allows for socializing, and it's a fun way for people to get together and raise awareness about perinatal mental health disorders. It usually takes place every summer, but again, with COVID, we don't know what's going to happen. This year we are not participating, but hopefully in the future we will. So I want to talk a little bit about legislation. In 2017, the Florida Families First Act was introduced by Senator Lauren Buck. In March of 2018, the state legislature for the first time addressed maternal mental health and passed the Florida Families First Act, giving provisions for a hotline and educational materials on postpartum depression-related illnesses. In summary, the version of the bill that was passed requires the Florida Department of Health to provide information on perinatal mental health resources through the existing family health line and revises requirements for birth centers to include mental health screening and information on resources given to postpartum women at discharge. The requirements of the bill go into effect January 1st, 2019. I will say again, this was a hallmark moment for us here in Florida, for us advocates of perinatal mental health, and was a wonderful victory. Further resources include 2020 Mom, the Postpartum Stress Center, Postpartum Progress, Postpartum Support International, and MCPAT for Moms. Videos and documentaries that we recommend are We Are Warrior Moms, Dark Side of the Full Moon, When the Bow Breaks, and PSI's Healthy Mom, Happy Family, Understanding Pregnancy and Postpartum Mood and Anxiety Disorders. I want to take this opportunity to thank you for listening to this presentation, and also wanted to thank my co-presenters, Kelly and Kim, as well as a big shout out to Shari Ann James for letting us build upon her PowerPoint. And again, I want to emphasize that we have to let our moms know that they are not alone, they are not to blame, and with help they will get better and will recover from their PMADs. Thank you so much and stay safe.